Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today we hear from Dr. Kelly Ridley, an addiction psychiatrist who discusses treating alcohol dependence with Dr. Olga Ward.
Kelly, welcome to the Distance is No Obstacle podcast.
Thank you very much.
Today I thought we might have a bit of a chat about alcohol consumption, subject dear to many of our hearts.
including mine.
Yep. So many of our patients actually believe that they're quite moderate drinkers, and I think they're probably comparing with their cohort. When you actually count up their units of alcohol, as you have to do often if you're logging them in as a new patient, or they've come in with a liver complication, or you're trying to work something out, you find that they're drinking really quite harmful levels.
Yeah.
So, got any tips for just breaking this very unwelcome piece of news to them?
Sure. And I guess I should preface by saying that actually most Australians are low-level drinkers or don't drink at all. But there's about 17% of people exceed the lifetime risk guidelines, so drinking more than 2 standard drinks every day. And about 25% of us exclude the risky drinking single occasion guidelines, which is more than 4 standard drinks in one occasion. But there is about 1 million Australians, so a lot of people who drink more than 8 standard drinks a day. So that's a bottle of wine equivalent or more every single day. And we know that the 2 biggest factors that increase that are being a man and living outside a metropolitan area. So if you think that maybe up to a quarter of the people walking through your door in Meekatharra or Merredin or Mora exceed those alcohol risk guidelines, it's important to put it out there. But I don't think that it's a breaking bad news kind of scenario. It's a fact-giving scenario because most people don't know what the guidelines are or don't know where their drinking fits in with that. As you say, you compare yourself to those around you. And if the people around you are drinking at a similar level to yourself, you may not realise that you're putting yourself at risk. So I often have a chart of what standard drinks are, particularly for bottles of spirits and pints and middies of beer, where it doesn't necessarily say it on the bottle in front of you. And I ask people, do you know what the current guidelines are in Australia around safe levels of drinking? And then talk to them about where they might be at. But it's just the start of a conversation.
Yeah, and I think it takes a little while for that information to sort of percolate and for them to decide whether they want to do anything about it or not.
Exactly, but it's kind of showing that, hey, I've been thinking about this, I know what the latest is, and I'm someone you can talk to about that.
Yeah. Now, the other familiar image that I think people have is of, they think of an alcoholic and they think about the vomit-stained drunk passed out in a gutter. But in fact, quite a number of the patients that I would consider to be really quite seriously alcohol dependent are, grandmas caring for kids at home or, somebody holding down a pretty high-powered professional job and who is drinking something much more sophisticated than a whole cask of cask wine every night.
Yep.
How do you even kind of get on side with them to talk about this is pretty much almost a dependency problem?
Yeah. Well, I think I'm an addiction psychiatrist, and it would make my job a lot easier if I could pick out my patients on the street from what they look like. But most people who are referred to me, who I see, as you say, working full-time or caring for children full-time and seemingly functioning well. So often the questions you have to start with are a bit more general. And trying to minimise some of that stigma around having an alcohol use problem. So I really take the tack of assuming everyone drinks alcohol and assuming everyone drinks at a risky level, and asking questions where people can kind of pull me back into line. So I always ask people, how many days out of the week do you not have a drink? Because if you ask people, how many days out of the week do you have a drink? Everyone says a couple. Similarly, I'll say, would you ever get through 3 bottles of wine a night, or 2 bottles of scotch, or a carton and a half of beer? Because people will pull you back and correct you. But if you say, oh, how many beers would you have of a night? Everyone always says, a couple. Maybe a 6-pack on the weekend, doc. I also sort of then approach the harms from alcohol, but not what's drinking done to you, if you stuffed your liver or whatever. I usually start with, have you ever done something or said something that you regret when you're drinking? Because that's quite a common experience, even for people who don't have an alcohol use disorder or a dependence. But it starts that conversation. And I move on to physical harms, like, do you ever get heartburn or gastritis? Do you ever feel really low or really dark after a big night drinking? They're common harms, but we're kind of easing into the conversation, because there is a real stigma around having a drinking problem in Australia, even though drinking is such a part of our culture. Putting your hand up and saying, I'm concerned about my drinking or the problems it's having on my health and my mental health is super hard for patients to do. You have to show that you know what those harms might be, so people can say, actually, yeah.
And often it's an incidental thing when you've done their liver function, and you have to kind of have a chit-chat with them about what might be causing this. And I would often put that into the context of their medication list, as well as how much they're drinking and whether or not there's anything else going on, and whether there are any genetic things that I need to be following up. It's not impossible to be an excessive drinker and have hemochromatosis.
Absolutely. And it's very very possible to be a long-term dependent drinker at quite heroic levels and have perfectly fine liver function tests. Whereas it's also possible to be an 18-year-old who's been drinking heavily for 6 months and be in liver failure. There's a bit of some unlucky genetics involved in that.
Yeah. Now, I haven't found the standard cage questions enormously helpful.
Yeah.
Have you? Do you use them?
I think about what the cage questions are asking. I think if you can't remember anything else in the cage ones that you learnt in medical school or for your exams, they're a good place to start.
Yeah.
But I do tend to think about what are the criteria for dependency and ask questions around that specifically. So when we're thinking about tolerance, asking if I'd met you a year ago, would you be drinking a different type of alcohol? Would it be more or less than now? Would it be more or over a longer period of time? If people say, no, it's always been a bottle and a half of wine, I say, well, do you find you get less drunk, less of a buzz than you did a year or so ago? And then we have to move on to a withdrawal syndrome, and that's really important for alcohol because alcohol withdrawal can potentially be deadly. And I usually start with, do you ever wake up with the sweats or the shakes? Have you ever had a fit or a seizure? What happened the last time you had to go without a drink for a day or two? Some people might not be able to answer that because they can't remember the last time they did that.
Yep.
And if people tell me that, I often ask them, do you ever need to top up in the night with a sip of beer? Do you keep some vodka by the bed? Things like that. In regards to cravings, which is an important criteria around dependence, sometimes I think patients feel like cravings are almost a positive thought, like looking forward to a drink, but they're quite intrusive and they can be quite unpleasant. So I often ask things like, do you spend much time thinking about your next drink or dreading your next drink? Because that is the experience for lots of people.
When they actually dread it.
Yeah, they don't want to keep drinking, and so the thought of, oh my God, I'm going to have to go home and drink a bottle of scotch, or I'm going to feel really awful. I really wish I had more of a control over this. So I'm thinking about drinking all the time, but I'm not looking forward to it. It's no longer pleasurable for me.
Yeah. And then, of course, in rural practice, we get the added problem of those patients who are quite dependent on either intermittent, what for a better term is binge drinking, or regular alcohol intake, and they come into hospital for something unrelated, or perhaps for the motor vehicle accident that they had because they were drinking to excess. And then they start to go into withdrawals. How do you pick that early if you've got no history?
I think it's being aware of it and being aware of the timeline of it. So alcohol withdrawal, depending on how much you drink and how often, you can potentially start experiencing symptoms after a few hours, but they tend to peak after 24 to 48 hours. So if someone's been sitting on the ward feeling fine and then a day into their stay, they're suddenly looking really tremulous and shaky and sweaty, and their blood pressure's going up and down and their heart rate's going up and down, it needs to be a clue that they're in a withdrawal of some kind. Certainly if people come in and they've blown 0.3 and they're conscious, it's a big sign that they might be alcohol dependent. Sometimes you're lucky and there's other blood tests that might give you a clue, or other hospital presentations or some collateral from other people. But it's really thinking about it, because as we mentioned, alcohol withdrawal is potentially deadly. If you get the DTs, the fatality rate's about 5%.
Heck.
Yeah, and it is a horrible thing to treat. And unfortunately, it is usually the people that come in for something else. They're septic, they've shattered a femur. Because if someone's coming in for an alcohol detox, you're on top of it. You're preventing these complications assertively. But it's often getting called as a psychiatrist to a surgical ward or a medical ward, because it looks like someone is delirious or having a psychotic break. They're so agitated, they might be hallucinating or paranoid, their blood pressure's all over the place, and people are saying, what's wrong with them, what should I do? And then you look at the timeline, they've been in hospital for a couple of days and all of a sudden become really abruptly unwell, and voila, it's the DTs.
And then how do you treat them when you spot them at that level?
Lots of benzos. So if you're lucky, you'll be able to give quite high dose regular benzodiazepines orally. If people are liver impaired, you might need to use something like clonazepam or lorazepam, otherwise diazepam's the preference. But for a lot of people with the DTs, they'll end up needing IV benzodiazepines, either because you can't get enough into them orally or they won't take it. They also need IV fluids, IV thiamine, because we want to prevent thiamine-related illnesses that are so common in people with alcohol dependence. They might need magnesium, they might need other electrolytes. And ideally, quiet care, but also supportive care. But often patients with the DTs need to be managed in ICU or high dependency units.
Yeah. What do they die of?
Seizures.
It's mostly the seizure.
And the autonomic disturbance. So you can get arrhythmias, you can have strokes, you can have cardiac arrests. Yeah. The autonomic disturbance is quite dramatic when you see someone's OBS chart. And when you see them, they look really sick.
Now, the other horror scenario for a rural GP, usually remote, often solo, is being called by the police, or being met at the hospital by the police with somebody handcuffed who's got acutely, horribly unwell in a cell.
Yep. And
trying to work out what's going on.
Yep.
Often very uncooperative patient, and often multiple substances.
Yeah.
Where do you even start with the enormous amount of assessment capability that we have?
Yeah, I mean, I try and be really blunt with people. I'm here to give you something to make you feel better, but I want it to be something that'll work for you and not cause you harm. Can you tell me if you've taken something, or will you be withdrawing from something at the moment? And I try and list a few things and get people to tell me yay or nay. If you're lucky, you'll get a urine sample and do a urine drug screen, but otherwise you kind of have to look at someone and make a guess. Do they look like they're stimulant intoxicated with big pupils, and maybe they're warm, and maybe they're sweaty, and do they look agitated? Or do they look like they've taken a depressant and they're breathing slow and they're looking zonked out? Yeah. But as you say, it's often a combination. And so in those cases, I always think you can put more medicine in, but you can't take anything out. So particularly when people are really agitated, they often get high doses of things in quick succession. injectable things like droperidol in combination with benzodiazepines, or some oral olanzapine and then some IM clonazepam, and all sorts of combos. But the key with anything, no matter the form you give it, you've got to give it time to have an effect before you give something else. Giving more things doesn't make that first thing work any faster. And then it stops the scenario where you potentially got someone in front of you that's over-sedated, and you either have to try and reverse it, something like flumazenil, or you have to ventilate them. And no one's the patient will not thank you for that, nor will your health service. So I try and give things in moderate doses, 5 to 10 milligrams of diazepam, 1 to 2 milligrams of clonazepam, and then you've got to just wait and give it time to work.
What's your wait time for those?
At least 10 minutes, but ideally 20. Yeah.
And you're talking injectables here?
Yeah, so a shorter period of time, but you've got to give it 5 minutes.
Yeah, you've also got to stop them thrashing for long enough to get the IV in, which is always a bit of a problem.
Yeah.
Once the patient has decided that maybe they need to or want to moderate their alcohol intake, what's actually available to them?
In terms of specialist services?
Yeah.
It really depends on where you live. Whether drug and alcohol services are run by NGOs or government services, whether they're co-located with mental health services or GP practices, varies so much from region to region, and that has a lot to do with both funding and how different places conceptualise addiction care. Often it's sort of shunted out somewhere that's neither seen nor spoke of, which I think is a shame. There is often phone services available no matter where you live. So there's the drug and alcohol support line. It's a 1-800 number, free for country and metro callers, and that's 24/7. There's always someone on the end of that line if you need to either talk about what services are available in my area. Do you, person at the end of this phone, think I might have a problem? I'm worried I'm going to have a drink right now. Can you talk to me? Can you talk about some behavioural strategies, some brief psychological support? There's also associated with that a friends and carers number that's 24/7 as well, that's staffed by volunteers. There's also counsellingonline.org.au that's based in Victoria through an organisation called Turning Point, and they've got phone or text-based chat or email and an online peer support network, which is really useful as well, particularly for people in really remote areas. They don't have to do it alone.
No, and I think sometimes the text is a lot less confronting for the patients than fronting up to an office where everybody actually knows who you are and where you're going and why you're going.
Yeah. It's probably worth saying as well that there is support for clinicians. If you've got someone in front of you or someone's just walked out of your office and you've rebooked their appointment, if you need some advice, there's also a clinical advisory service run through Next Step in Perth.
Yep.
So Monday to Friday, 8 to 8. It's just for clinicians. You can't refer patients through that line. But if you want to run something by them or get specialist advice, you can speak to addiction medicine specialists. So if you want to manage this patient, awesome, you can get some help to do that.
Yep, very helpful they have been, I must say. What about those patients who are, you can see that they're well and truly alcohol dependent, and they're generally or often quite motivated to give up. Do they have to give up completely, or is there some hope that they could still have a couple of champagnes at their granddaughter's wedding?
It so much depends on the person. I've met plenty of people who are high dose, heavily dependent on alcohol, and have been able to turn into what we call controlled drinkers, which is I'm going to drink as much as I want in a time that I want. So the people who can have a couple on the weekend or a couple at Christmas and things like that. But there is also a large proportion of people who aren't able to control that drinking. So, alcohol affects your frontal lobe. it's really hard to stop once you start if you're dependent on alcohol, or even if you're not. Sometimes, I'm sure we've all had the experience, if you drink alcohol, of going to have one glass and then, whoops, I had 3 instead, because it affects our inhibitions in that way.
Yeah. And I can remember one of my patients who was actually part of a very small local support network, and he said he was battling if he took the lid off the metho.
Yeah. It's a bit
that was
like
quite confronting for me, because I hadn't thought just how much of a struggle this poor man must have had every single day.
It's a bit like when you're dependent on something, you form a pathway in your brain, and it's a bit like walking a path through the bush. If you've walked that path every day for years and years, it is really well developed. And if you spend some time away from alcohol, it will grow over a little bit, but will always be there. And for some people, it only takes that one trip back down the path, and it's like you never were away. It's just as clear as it was the last time that you had a drink, because you're so high risk at going back to dependency if you were dependent once. Some people are lucky, and that their path grows over enough that they can wander through on occasion, and they can navigate that safely. But I generally recommend to people, if you would like to try and be a controlled drinker, you need to have an extended period of sobriety first to get that path overgrown a little bit, to get out of the habit of it, and just to give yourself the best chance of success. And have the experience of being a person who doesn't drink alcohol. What would that feel like for you? And often that helps us uncover as well, is there other things that are going on that need to be addressed for you to then be able to have a more healthy relationship with alcohol?
Sounds like there's some hope for our patients and some help out there.
There definitely is, or I wouldn't do the job that I did. We do have success. Patients are marvellous, and people want to have healthy relationships with the things they put in their body. No one ever grew up saying, I would love to be dependent on alcohol, thank you. But there's certainly plenty of things that can be done.
Super.
Thank you.
Kelly, thank you.
Thanks.